Today, we're going to talk about hemodynamics and hemodynamic monitoring. We're still in the concept of perfusion. Think about the principle of blood flow, but also think about the heart as a pump. Critically ill clients need continuous assessments of their cardiovascular system to diagnose and manage their complex medical conditions. We use hemodynamic monitoring to achieve this. So up until this point, if you knew it or not, you were monitoring your patient's hemodynamics, maybe indirectly or not invasively. So for example, when you take a blood pressure, you're measuring blood flow. It's non-invasive. Maybe when we assess cap refill, we're assessing blood flow. And also when we do our pulse ox or O2 sats, we're monitoring blood flow and oxygenation. Just remember, when we talk about pressure, that fluid flows from a region of higher pressure to one area with lower pressure. So it goes from high to low pressure. Also remember, when we talk about pressures, we have to think about blood flow with the heart during systole and diastole. So if you've watched the A&P review for cardiac, remember systole is our heartbeat contraction. So when the heart contracts, and then diastole is when the heart relaxes and fills up. So hemodynamics are physical factors that govern blood flow. You can think of them as three things. We have pressure, flow, and resistance. So it's the study of blood through the body. We use hemodynamics to describe the intravascular pressure and flow that occurs when the heart muscle contracts and pumps blood throughout the body. So hemodynamic monitoring we use to assess the cardiac function, but we also use it to determine the effectiveness of therapy. Are the medications that we're giving effective? For example, when we give Lasix, we're volume depleting the patient. Maybe the patient had fluid volume excess, and now we give them Lasix to bring it down. You'll see a change in their hemodynamics. So we already talked about non-invasive hemodynamic monitoring, like with our blood pressure, cap refill, maybe even our urine output. So if we have good urine output, then we know that our kidneys are being perfused well. However, if we're doing invasive cardiac monitoring, we might do CVP, which is central venous pressure. We might use a PA cath, a pulmonary artery cath, or an A-line or arterial line. But we can use these lines to invasively monitor and measure hemodynamic measurements. The efficiency of the cardiovascular system really depends on three things. So the heart as a pump, is it effective? Is it not effective as a pump? Our vessels' patency, aka vascular tone, whether our vessels are dilated or constricted, and then the quality and quantity of blood. So quality, is our blood rich? Do we have enough hemoglobin? Do we have enough oxygen? And then quantity, do we have enough for blood flow to be adequate? There are factors that influence hemodynamics. The first one is our intravascular volume. So we want the volume to be in our vascular space. We don't want to be third spacing and have fluid in our tissues. We want it in our vessels so that it gets transported and distributed to the tissues. So the volume, how much blood we have in our vessels. The second one is inotropy. So inotropy is the force of myocardial contraction. Inotropy can be positive or negative. So if we describe something as a positive inotrope, or it has a positive inotropy factor, this is going to increase the force of cardiac contraction. If it is a negative inotrope or negative inotropy, this decreases the force of contraction. The next factor is vasoactivity. So our blood vessel activity, do they dilate? Are they constricted? So if our blood vessels are dilated, what is that going to do for our blood pressure? It'll actually decrease our blood pressure. If our vessels are constricted and we have vasoconstriction, what will that do to my blood pressure? It will increase it. And the last factor is chronotropy. So chronotropy is the rate of impulse formation. So if we have a positive chronotrope, the sympathetic nervous system is stimulated. Remember, we can say for the sympathetic, it speeds up, or Sir Speedy. This is going to increase our heart rate because it's the rate of impulse, right? So we're talking about heart rate. If it is a negative chronotrope, what's that other nervous system that's opposite of the sympathetic? Right, the parasympathetic. And remember, parasympathetic, we can say, is pokey slow. It's going to decrease our heart rate. So there are many hemodynamic measures, but the three main ones that we're going to talk about first are preload, contractility, and afterload. So preload, think about pre, so before, so it's the stretching of the myocardium at the end of diastole, so directly before systole, so right before that heart is going to eject all that blood out. It is when the ventricle is the fullest. So with preload, think about volume in the heart, the volume awaiting to be ejected. Preload will be increased with heart failure or hypervolemia, fluid volume excess. Preload will be decreased with hypovolemia, simple hypovolemia. When we talk about cardiac output, a lot of times cardiac output and preload can be indirectly measured together. So if we have simple hypovolemia, say I'm just mildly dehydrated, my cardiac output may initially increase to compensate. So some examples that might decrease our preload. So think about volume coming back to the right side of the heart. What are some drugs that would decrease that? Maybe some drugs that vasodilate, like venous vasodilate. One example is nitroglycerin. So nitroglycerin is a vasodilator. If it's vasodilating, then that blood is going to pool in my periphery and not return to the right side of the heart. This will reduce our preload. Another example could be furosemide or Lasix. So with furosemide, we're getting rid of volume. So if I'm getting rid of volume, then I'll have less volume to return back to the heart, thus decreased stretch, thus decreasing preload. The second term is contractility. So contractility, think about the shortening of those muscle fibers. So remember, when the heart gets really full, those muscle fibers are stretching, but then when they contract, they're becoming shorter and ejecting that blood volume out. So with contractility, you can think of contractility as stroke volume. So with each heartbeat, the volume of blood that's being ejected is directly related to contractility. Contractility can be increased when we have positive inotropes like digoxin and dobutamine. They increase myocardial contractility. Some things that decrease contractility, maybe our patients had an MI and those heart muscle cells have died and necrosed. Beta blockers directly affect contractility and decrease it. Remember, low and slow, they help rest the heart muscle by decreasing the workload, and this is how. The last term we're going to talk about initially is afterload. So afterload is the pressure that ventricle has to overcome to get blood ejected out. So let me say that again. Afterload. So preload was before, afterload is after. So it's that pressure that the ventricle muscles have to generate to overcome that high pressure to get blood out of the heart. So an example of afterload could be, and we'll talk about this here in a second, is our SVR, our systemic vascular resistance, or our PVR, pulmonary vascular resistance. So systemic vascular resistance, just the pressure in our system, our vessels, so arterial, how hard does that left ventricle have to squeeze to get blood out into the aorta, into the body? So if we're vasoconstricted, the heart's going to have a harder time, that left ventricle is going to have a harder time getting blood out. So it might increase our afterload. If we're vasodilated, that might decrease our afterload because that left ventricle is going to have an easier time getting blood out. So afterload can be increased with vasoconstriction, whether it's our body's compensatory mechanism doing it or from vasopressors. Afterload will be decreased with vasodilation or vasodilators. So we talked about systemic vasodilation, but with pulmonary vascular resistance, we're talking about the right side of the heart. So the right side pumps to the lungs. So how is the pressure in my pulmonary vasculature? If it's high, like say I have pulmonary hypertension, that right ventricle is going to have a hard time squeezing blood out. An example that could decrease afterload with the pulmonary vascular resistance, so right-sided afterload, could be Viagra. Yes, Viagra. It's used for other things. However, when it was first developed, it was used to treat pulmonary hypertension because it dilates those pulmonary vessels. Once they started doing clinical trials and saw the other effect of it, well, that other effect is more marketable, and thus Viagra has been created. Now in clinical, you might see your patients on Viagra during the day and not just PRN, and you might even see a woman on Viagra, and it's not for the sexual effect, it's for the pulmonary hypertension effect. Other examples that can decrease our afterload are ACE inhibitors. With ACE inhibitors, they block the conversion of angiotensin 1 to angiotensin 2, and remember that prevents vasoconstriction, so it's going to decrease our systemic vascular resistance and increase our cardiac output, but also decrease our afterload. So if we're vasodilating, we have less resistance that left ventricle has to overcome to shoot blood out of the heart. So when we talk about afterload, with afterload and stroke volume, there's an inverse relationship. So that means if afterload increases, then stroke volume decreases. If afterload decreases, then stroke volume increases. So stroke volume is the amount of blood pumped out of the heart with each heartbeat. So if my afterload is increased, so maybe I'm vasoconstricted, that left ventricle has to push really hard to get that blood through and out to the body, that's going to decrease my stroke volume. Now just the opposite. If my afterload is decreased, so maybe I'm vasodilating, I will have an increase in my stroke volume because more blood can get out due to the decrease in resistance. So vasodilators, remember they decrease blood pressure because they vasodilate. They're going to decrease our preload. However, if they also arterial vasodilate, like nitroglycerin, that'll also affect our afterload. So nitroglycerin actually affects both preload and afterload because it vasodilates venously and arterially. When we talk about beta blockers, we say they decrease our heart rate and blood pressure because they block beta. Let's bring that a little further. So what do? How do they decrease our heart rate and blood pressure? Well, they decrease contractility, decrease the workload on the heart. They decrease systemic vascular resistance because they vasodilate. They also decrease pulmonary vascular resistance because they dilate the pulmonary vasculature. And they also increase our cardiac output because it makes it easier for the blood to get out of the heart. And remember how they decrease heart rate is through sympathetic tone. They block sympathetic tone. So remember our sympathetic nervous system speeds things up? Well, it's going to block that to decrease our heart rate. We talked about furosemide and diuretics. They help decrease our blood pressure, help us expel volume, thus will decrease our preload. So if we're getting rid of volume, less volume is being returned back to the right side of the heart. And then ACE inhibitors, they decrease blood pressure because they block that angiotensin 1 converting to angiotensin 2, which is a potent vasoconstrictor. If they're not allowing vasoconstriction and they're causing vasodilation, then more blood is going to pool in that periphery and not return back to the right side of the heart, thus decreasing our preload. Who knew that we could tie these three things to different drug classes? Now, if you look at the slide, it's kind of a great way of describing preload, contractility, and afterload with the balloon. So preload is our blowing up of the balloon. How much air we can get into that balloon and stretch those muscle fibers. So think about the balloon as the ventricle. So then the balloon stretch is our contractility. So if you've ever had to blow up balloons for a birthday party, as soon as they come out of the bag, they're very hard, right? Sometimes you stretch them before you blow them up to make it easier to blow up. But after time, if you continue blowing up the same balloon, that balloon's going to become baggy. So kind of the same concept with the heart. We keep blowing it up till it stretches and stretches and can't stretch anymore. It's going to become baggy and not contract as effectively. So that's important when we talk about heart failure. Those hearts have been stretched so much because these patients have fluid volume excess that eventually they don't shorten or contract back to normal and they become baggy. So then afterload is the knot. So we tie a knot at the end of the balloon so no air escapes. So if that knot is tight enough, that air can't get out of the balloon. Now, if we don't tie the knot tight enough, maybe a little bit of air escapes over a short or long period of time, depending how big or how loose that knot is. But just think about when we talk about afterload, remember it's that ventricular muscle and how it has to push against the high pressures, maybe in the aorta or in the pulmonary system to get blood out. So Starling's law, it states that the force of myocardial contraction is directly determined by the length of the muscle cell fibers. So the longer the fibers get, that means they're stretching more, should be more blood ejected out. Now within a certain range, when we increase those myofibril stretch, this will increase the force of systole, thus increasing our stroke volume or cardiac output. However, there is a point of no return. So we talked about in the last slide with heart failure, if those myofibril fibers become overstretched, for extended periods, like with fluid volume excess or heart failure patients, this will actually decrease our contractility. So normally the ventricle is filled with blood, so those myocardial fibers stretch just right before systole, so how long they are. Once the heart contracts, those fibers go back down and shorten. So think about a rubber band. We stretch it, it shortens. We stretch it, let go, it shortens. Same thing with the heart. But over time, we keep stretching that rubber band and keep stretching it. Eventually, it's not going to go back to its normal size. So same concept with heart failure. So here's a good visual for preload and afterload. So preload, remember pre, so it's the volume of blood going into the right side of the heart, goes into the right side of the heart, goes through the lungs, goes back to the left side of the heart where it's ejected out into the body. And remember, afterload is the resistance that that ventricle has to overcome. So it could be left or right, but this is a picture of the left side. So if you see on the aorta, there's a clamp. So that vessel is clamped down, so it's vasoconstricted. That's going to increase our afterload because the left ventricle is going to have a hard time getting that blood out. So let's talk about the hemodynamic measurements or calculations that we actually do in clinical practice. We can measure cardiac output, stroke volume, the mean arterial pressure or MAP. We can measure systemic vascular resistance or SVR, pulmonary vascular resistance or PVR. We can measure central venous pressures or CVP, pulmonary artery pressures or PAP, and then our pulmonary capillary wedge pressure. You might also hear this called wedge pressure or pulmonary capillary occlusive pressure. They're all the same thing for the same term. So let's dive deeper and talk more about these measurements. So our first measurement we're talking about is cardiac output. So cardiac output is the amount of blood the heart pumps in 1 minute from the left ventricle. It's measured in liters per minute. Normal is 4 to 8 liters per minute. And there's a couple things that cardiac output depends on. It depends on the size of your patient. It also depends on the metabolic needs of the body. So say I'm running a marathon. My metabolic demand is really high, so my cardiac output might be more elevated. Now, if I'm just sitting in class listening to lecture, my metabolic demand may not be that high, and my cardiac output might be on the lower normal side. But normal is 4 to 8. There is another measurement called cardiac index, and it's basically the cardiac output, and it involves the body surface area of the patient. So it actually takes the size of the patient into account. Stroke volume, we've kind of talked about, but to put a formal definition, it is the amount of blood ejected by the left ventricle with each contraction. Stroke volume is directly affected by preload, afterload, and contractility. Average/normal is about 60 to 100 milliliters per beat. So with every beat of the heart, 60 to 100 milliliters is being ejected out. So let's put these two together. So with cardiac output, we can say cardiac output is equal to the stroke volume times our heart rate. So each heartbeat, how much volume is being ejected out, times the heart rate, which is our beats per minute. So let's talk about how an increased heart rate can affect cardiac output. So initially, an increased heart rate can be a compensatory measure to help perfuse our organs. But over time, if our heart rate is increased, say over 150 beats per minute for a length of time, it will actually cause a decrease in our cardiac output. So an increased heart rate, so we're talking about greater than 150 beats per minute, will increase our myocardial oxygen demand, decrease our ventricular filling time, so the heart's beating so fast those ventricles can't fill, thus will decrease our blood that's being ejected with each heartbeat. Now think about when we exercise. Let's go back to that running a marathon or just simple aerobic exercise. Initially, our target heart rate may be greater than 150, but we don't want that for 12, 24 hours. It's just temporary. You won't see those decline in cardiac output. Now, if it's for a length of time, yes, you'll start seeing the heart fail as a pump. Stroke volume cannot be measured indirectly or directly. It's actually calculated, and it involves our MAP and CVP. So with stroke volume, just remember it's the volume of blood the heart beats out with each beat. So if we have decreased venous return, so decreased preload, that's going to decrease our stroke volume. If we have increased venous return, say from vasoconstriction, that's going to increase my stroke volume, might even increase contractility. So just another picture, cardiac output's equal to our heart rate times our stroke volume. So systemic vascular resistance, or SVR. It's the resistance to flow that must overcome to push blood through our circulatory system. So the resistance offered by the peripheral circulation is called our SVR. So how our vessels respond. Are they clamped down? Are they dilated? So SVR is the resistance that left ventricle has to overcome to pump the blood. It's affected by our vascular tone in the diameters. It's also affected by the viscosity of our blood. Remember, SVR has an inverse relationship with cardiac output. So if our cardiac output is increased, then our SVR is going to be decreased. So that pressure in the vessels is going to be decreased. So I might be vasodilated so the heart can get that blood out effectively. Just the opposite. If I have a decreased cardiac output, so not a lot of blood is getting out of the heart, maybe my SVR is increased. So maybe I'm vasoconstricted. That'll also increase our afterload. So with SVR, we can also think about it as maybe left ventricular afterload. So with systemic vascular resistance, so here we're looking at the left side of the heart, so we're talking about left. Think about exercise. Let's go back to an example. So with exercise, our heart rate increases, our contractility increases. This increases our cardiac output because we have more blood coming back to the heart, i.e. more preload or venous return. Venously, we're vasoconstricted to bring blood flow back to the heart to increase our cardiac output. Then arterially, we're vasodilated. So this will decrease our SVR because we're talking about the left side. So decrease our SVR, those arteries dilate so that we can get more blood and oxygen and nutrients to the tissues. And since I'm vasodilated, it's also going to decrease my afterload. And remember the inverse relationship, so this is going to increase my stroke volume and cardiac output. So think about the arteries dilate, the left ventricle requires less force or less resistance to push blood out of the body. So blood pressure. When we take a blood pressure, yes, we're getting some numbers and we're recording it and trending it. But really, when we're doing a blood pressure, it's our cardiac output times our systemic vascular resistance. So we talked about SVR, let's talk about PVR, or pulmonary vascular resistance. Pulmonary vascular resistance is the resistance that the vasculature of the lungs has. So it's similar to SVR, but instead of systemically, we're talking about the pulmonary vasculature. So the resistance of blood flow through that pulmonary vasculature. And again, it's affected by vascular tone and diameter. We can think of PVR as our right ventricular afterload, so the force that that right ventricle has to push to overcome and get blood into the pulmonary vessels. When we talk about PVR, the only way to measure it is invasively. So it's measured and calculated using a pulmonary artery cath and a wedge pressure. Some things that can increase our pulmonary vascular resistance could be a client who has pulmonary hypertension, maybe COPD. Things that would decrease our pulmonary vascular resistance could be those medications like Viagra that actually dilate the pulmonary vessels. Could even be nitric oxide. So putting it together, we talked initially about preload, contractility, and afterload. If you keep going down in this picture, we can say that the stroke volume is directly related to preload and contractility and afterload. But then our cardiac output is made up of stroke volume, which is preload, contractility, and afterload, times our heart rate. So central venous pressure, or CVP. CVP measures the pressure in the right atrium and the vena cava. So we're talking about the right side of the heart. It reflects the filling pressures in that right ventricle, or preload. So CVP is actually a measurement of preload. So it's on the right side of the heart. It's the pressure in that right atrium, so all the blood flow that's coming back to the heart, thus preload. You may also see CVP called right ventricular end diastolic pressure. All that's saying is at the end of diastole, what is the pressure in that vessel or in that ventricle? We use CVP to assess right ventricular function and general fluid status. So for measuring all the fluid coming back to the heart, we can actually measure their fluid status with a CVP. CVP may also be called right atrial pressures, or RAP. But again, it's the measure of the amount of volume entering that right ventricle or right atrium. Normal CVP, you'll see anywhere, it might say 2 to 6 or 2 to 8. So just know 2 to 8 is normal. So if our CVP, or right atrial pressure, is decreased, that means less volume is being returned to the heart. So if we have decreased CVP, so less than 2, maybe we're hypovolemic. Maybe I have vasodilation from drugs or a pathological process, decreased blood flow back to the heart. Maybe from diuretic therapy. With increased CVP, so more volume back to the heart, could be maybe I have fluid volume excess or hypervolemia. Maybe I have a valve that's stenosed and hardened, so blood flow is kind of backing up in the heart. Maybe I have right-sided heart failure. That heart muscle is very stiff and blood flow is backing up. Could also be caused from pulmonary hypertension. So those vessels in the pulmonary vasculature, the pressure to get blood flow in there is high. So that's going to decrease or increase our pressures on the right side, thus increasing our CVP. Cardiac tamponade will actually increase CVP because blood flow is backing up. If I had a right ventricle infarct, so I had an MI that affected my right ventricle, it may cause right-sided heart failure, thus increasing our CVP. Another thing you might see is if your client has a PE, so a blood clot in that pulmonary vasculature, that right side of the heart's going to have a hard time pushing against that PE. So that's going to increase pressures on the right side, thus increasing our CVP. With CVP, it's measured with any central line that terminates in our SVC, like a multilumen. Remember when they insert a multilumen, so a central line, that tip or the end of that central line terminates in the superior vena cava, so it sits right before the right atrium. So it can actually measure our CVP. PICC lines do this also. Now those midline catheters, they don't thread that far, so you can't measure a CVP with those. We can measure CVPs with pulmonary artery caths also. Another invasive device that we use is an intra-arterial blood pressure monitoring catheter, or you may just hear it called an arterial line or A line for short. But it's a catheter that's placed in an artery. It's kind of like an IV, but instead of placed into a vein, it's in an artery. The angiocath part of it, the tip, is a little more stiff than a traditional IV. We can place them in any artery, like a radial artery is usually your most common, which is in the picture there. Maybe femoral, axillary, or even ulnar. When you did your NICU rotation, you might have seen umbilical lines, and those are directly placed in an artery. But the pressure from the artery is transmitted to a transducer by some fluid, does its magic, and converts pressure into a tracing that we see on our monitors. Why might someone need an A-line? There's a couple reasons. One, we may be titrating vasoactive drugs and need an accurate measurement or frequent blood pressures. If we're having to use a cuff pressure every minute or so, that might tire somebody's arm, may even break down their arm. We might even use it if they're unstable. So if they have cardiac instability and we can't obtain a cuff blood pressure, we might insert an A-line to directly measure their blood pressure. You may also see A-lines for frequent ABGs. If somebody's having frequent blood draws or arterial blood gases, well, let's just put an arterial line in, and then we can directly get the ABG out of that arterial line. We can draw other labs. However, with an arterial line, we cannot infuse medications. So medications are only administered via veins, because think about veins, they'll go back to the heart and the heart will eject it out to the vital organs like our liver and kidneys. If we infuse meds in an artery, it will only go distally and not back up to the heart. So we can draw labs, draw ABGs, and measure blood pressures with an A-line. We cannot infuse medications. There are some complications, maybe ischemia to that limb or digit, so our fingers distally. Maybe a hematoma forms around it, an arterial dissection where that artery actually tears, maybe an air embolism from air being introduced through the system, possibly infection because we are going through that first line of defense, maybe pain, maybe an arteriospasm, so that artery may spasm and clamp down. With arterial blood pressures, it's important to note that they will not correlate with our cuff or our non-invasive blood pressures. You might see nurses still put them on to measure cuff pressure every once in a while, but just know that they may or may not correlate, and that's okay. When we talk about our pressure lines, these lines, the tubing that hooks to them is a little bit stiffer than your traditional IV tubing because we're having to measure pressures, so it needs to be stiff and not bend quite as much. They also have transducers. So these transducers are where the magic happens, but they have to be placed at a certain spot in the body. So with the transducers, they have to be placed at this phlebostatic axis, which is the intersection of our fourth intercostal space, mid-axillary line. And that's where the atrium are in your heart. So this phlebostatic axis, the point never changes. However, when the position of your patient changes, that point may move, but it's still the fourth intercostal space, mid-axillary line. When we're inserting arterial lines, usually the radial artery is our most common, which is what you see pictured there. We have to perform a Allen's test prior. So with the Allen's test, what we're doing is to ensure that we have adequate collateral circulation. So if we're putting the arterial line in the radial artery, I still have an ulnar artery that can supply blood flow to the hand if that radial artery becomes compromised from that arterial line. So say I have an arterial dissection and that artery can no longer pump blood, the radial artery can no longer pump blood to that hand, well, I have an ulnar artery that should supply the collateral circulation, and that's what we're testing for. So what you do is you have the patient elevate their hand and make a fist for 30 seconds, and then we compress the radial and the ulnar arteries simultaneously, causing the hand to blanch because that hand's not getting blood flow. After the client opens their fist, so you'll see that their hand becomes really pale, we'll release pressure on the ulnar artery, but keep pressure on the radial. So release the ulnar, keep pressure on the radial. So if something happened to the radial, hopefully the ulnar will pick back up and that hand should pink back up. If not, then we probably have some sort of perfusion problem and we need to find another site for that arterial line to be inserted. You might even see them use ultrasounds before, like a Doppler, to assess blood flow rather than doing the Allen's test. So let's watch a video on the actual Allen's test.
Perform a modified Allen's test. Information. Both the radial and ulnar arteries supply the hand with oxygenated blood. These arteries anastomose in the hand. In a small percentage of people, this dual blood supply is absent. The Allen's test is used to test the collateral blood supply to the hand, specifically the patency of the radial artery prior to radial arterial blood sampling or cannulation. Follow these steps to perform the modified Allen test. With the middle 2 or 3 fingers, not the thumb, locate the pulsing radial and the ulnar arteries of the palm side of the wrist. See illustration. Keep in mind that the ulnar artery is smaller and more difficult to locate. Ask the patient to make a tight clenching fist for about 30 seconds. Apply firm pressure over the ulnar and the radial arteries, occluding both of them. The hand is now open, and the palm and fingernails should appear blanched. The pressure over the ulnar artery is released, and the color should return within approximately 7 seconds. The Allen's test is negative when the normal color returns within plus or minus 7 seconds, indicating that the ulnar artery is patent and is able to maintain a sufficient blood flow to the hand, even if the radial artery is occluded. The Allen's test is positive when the normal color of the hand does not return within the specified time period, indicating that ulnar circulation is inadequate or non-existent.
So with an A-line, there are some nursing care that we need to talk about. One, we need to monitor the pulse and cap refill and the skin temperature of that extremity, temperature and color. Another thing you can do, and a lot of new evidence is suggesting, like in the picture, on one of those extremities on the hand that the A-line's in, put your pulse ox. When we do our pulse oxes in ICU, you get a waveform, And if you have a poor waveform, then that means you have poor perfusion to that extremity. So if we notice that there's poor perfusion, then maybe that artery is compromised from that A line. You might even need to restrict that joint or limb. So say it's in our radial artery. If your patient keeps bending their wrist and tightening up, you might have to put a board to restrict it. Other things you might see is your patients after they come back from a heart cath, if they've had some sort of intervention, that sheath might still stay in their leg and they hook it up to an arterial line system. So they have to keep that leg straight. We want to assess at the insertion site for infection, any bleeding, hematoma, redness, hardness, or any kind of drainage that's not normal. With the A-lines, they're not routinely changed. Usually they're just kept in place until A, we no longer need them, or B, they go bad and we can't accurately measure blood pressures anymore. We can change the dressing, the tegaderm, a clear tegaderm, every 72 hours, just like an IV. We're going to change the tubing that's attached to that A-line, so the pressure tubing, every 72 to 96, really depending on your facility. Just like an IV line, you change the tubing. It's a different type of tubing though. And then we're going to zero our line with any position changes. So when we zero, what we're doing is taking that transducer, putting it at the phlebostatic axis, and doing some things on the monitor to zero it. Kind of similar to when we talked about ICP in the EVD drains. So with that transducer, if it's held above the heart level, you're going to get a falsely lower reading. Now just the opposite. If that transducer is held lower than the heart level, you might get a falsely elevated reading. So that's why we need to zero it and place it at that phlebostatic axis. Another thing we need to do is watch our waveform for accuracy. Let's watch this video about setting up an arterial line. So you saw in the video the setting up of an arterial or a pressure line. So the pressure tubing is different than traditional IV tubing in the fact that it's more stiff because we need it to be stiff to accurately measure pressures. Also, did you notice that that IV bag was connected to a pressure bag? So all that pressure bag is putting pressure on the IV fluids so to go into that line so that it puts pressure against our arterial line. If we didn't have that pressure, then blood would actually regurge back into that line and clot our line off. So make sure when you go in your room and you're assessing your patient, when you talk about their pressure lines, look at your pressure bag, make sure you have enough pressure. In the video, it said 300 millimeters of mercury. Most of our pressure bags actually have different green, yellow, red color codes on it. You want it in the green. If it's in the red, it's not enough. So be sure to look at that. You also saw that we can obtain lab samples. So remember, it's arterial blood, so we can do ABGs. So when we talked about setting up our pressure monitoring device and tubing, remember the transducer has to be at the level of that phlebostatic axis. And here's a picture. Remember, it's the intersection of the fourth intercostal space in our mid-axillary line. So remember, it's the level of the atria in the chest. Also, if our client is repositioned, like the head of bed is increased or decreased, we have to zero the system and put it at the phlebostatic axis again. So standard of care is to zero at least once per shift and with any position changes. So here's a picture of our patient who has an arterial line. If you look, the transducer is actually attached to the IV pole, and it's at that phlebostatic axis. So our transducer can either be on an IV pole beside the patient as long as it's at that line or level. You may even see it attached to like a towel roll, and that towel roll actually being placed between the patient's chest and arm at that phlebostatic axis. Either way is fine. While we're inserting arterial lines, we have to talk to the patient and family, explain the procedure and its purpose. The client's going to be awake. It's like an IV stick, just a longer needle. We need to assess our insertion site every hour. We're looking for redness, swelling, drainage, pulse, see if there's a hematoma, the color, temperature, cap refill of that extremity. We need to document our date and time, our site, the type of solution we're using for a flush solution could be normal saline or D5W. The type of dressing applied, so a tegaderm, and then how the patient tolerated it. We may need to immobilize that extremity. We need to assess our waveforms, make sure we have accurate waveforms, and then again, zero with any position changes, but at a minimum, once a shift. So when we talk about our waveforms with an arterial line, we're looking inside an artery with this line. So you're going to see systole, a dicrotic notch, and diastole. So remember systole, that's when the heart contracts, so that aortic valve opens, blood's ejected from the left ventricle. You'll see a sharp rise in that waveform. And remember, we're talking about arterial, so we're just talking about the left side of the heart. Then on that waveform, you'll notice a dicrotic notch. And what that dicrotic notch signifies is the closure of that aortic valve, which is the beginning of diastole. So then the last part of the waveform is diastole. So it's the lowest point recorded on that waveform. So when the heart is at rest and filling. So here's an actual waveform. and how it correlates on the EKG. So if you notice, at the end of that shaded pink is our dicrotic notch. We want to see a dicrotic notch on our arterial lines. That means A, they're in the right place, and B, that line is still working. If you don't find a dicrotic notch, maybe reposition that extremity, maybe immobilize that extremity, flush your line, and recalibrate and re-zero. If you still don't see a dicrotic notch, chances are A line has probably gone bad and possibly needs to be removed. When we talk about removing our arterial lines, remember it's in an artery, so we're going to have to hold pressure at least 5 or 10 minutes. Don't peak, just hold continuous pressure. And then we may even apply a pressure dressing for a period of time. So our mean arterial pressure, or MAP, it reflects the arterial pressure in the vessels perfusing our vital organs. So vital organs are our heart and lungs and brain. Normal MAP is 70 to 105 millimeters of mercury. It reflects the changes in the relationship between cardiac output and SVR, so systemic vascular resistance, because it's the average pressure at which blood moves through the vasculature or vessels. So we need at least 65 millimeters of mercury for the cells to receive enough oxygen and nutrients. With a low MAP, so a low MAP, so less than 70, indicates decreased blood flow to the organs. So we need at least 70 for adequate renal perfusion. So that's why when we talked about urine output being a measurement for hemodynamics, that is why. If we don't have enough blood or blood volume, our MAP may be low and blood may shunt to the vital organs, so the heart, the brain, and the lungs, and not go peripherally. That's when you might see the kidney shutting down because they're not getting blood flow. This is why. If we have an increased MAP, it just indicates an increase in cardiac workload, so that heart's having to work really hard. There is a formula to calculate our MAP. It's basically our diastolic times 2 plus our systolic, all of that divided by 3. Now, I won't make you calculate an MAP because when you do cuff pressures, what's that number in the parentheses? That's our MAP, right? So here's some evidence-based interventions for preventing infection with our arterial lines. We don't routinely replace them. They go bad, we take them out. We don't replace them at every 96 hours, say. We just leave them in. We are going to assess them daily for signs of infection or distal ischemia, so your digits, your fingers, look for blood flow, cap refill, color, and temperature, or signs of embolization, so maybe a clot formed at the end of that line. We replace our transducers every 72 to 96 hours. That includes the tubing, the flush, the solution, everything but the actual catheter. We can replace the dressing when it becomes damp or loose or soiled. So if our patient is diaphoretic, we might have to replace it because it's not going to stick, and remember, moisture increases our chances for infection. When you're replacing your transducer, you're also doing your tubing and solution all at the same time. And then you're replacing the fluids along with it. So every 72 to 96 hours. So the next thing I want to talk about is an invasive line that we can use to measure further hemodynamics, and it's called a pulmonary artery catheter. So it's a form of a central line, but remember with central lines, the tip of that central line sits in the SVC, so directly above the right ventricle. With pulmonary artery caths, They are what they say. The tip sits in the pulmonary artery. So the pulmonary artery cath is still on the right side of the heart. If you look at our picture here, it's threaded. Here it's threaded through the inferior vena cava, so we might be going through the femoral, going up through the inferior vena cava into the right atrium, through, what's that valve on the right side? The tricuspid. Remember, tricuspid R has an R in it, so right-sided. So through the tricuspid valve into the right ventricle, through, what's our next valve? That's right, the pulmonic valve, where that tip sits in one of the pulmonary arteries. So remember, arteries go away from the heart. Our pulmonary artery is going away from the heart into the lungs. And fun fact, the pulmonary artery is one of our only arteries that is deoxygenated. So one of the brand names for our pulmonary artery caths is Swan-Ganz, and that's the two physicians that created it. So you might hear it called a Swan or a Swan-Ganz or a PA or pulmonary artery catheter, all the same thing. We use them for conditions like shock or sepsis, or maybe routinely after cardiac surgery. We can evaluate fluid volume status, cardiac output. We can evaluate a client's response to treatment by directly measuring these hemodynamic values. We can use a pulmonary artery catheter to infuse IV fluids, medication. We can also draw blood or mixed venous oxygenation samples. We can also use a PA catheter to measure core temperatures, so the temperature of the blood inside the patient. Pulmonary artery catheters, we talked about, we can measure our central vascular pressures, so central venous pressures. We can measure cardiac output and core temperatures, obtain our mixed venous blood samples. We can indirectly measure the left side of the heart, so the left ventricular end diastolic pressure. We can evaluate hemodynamic treatments and statuses and measure the client's status. Usually pulmonary artery catheters are seen in critical care units, maybe cath labs. They may be inserted in the ED, but most of the time they're inserted in a cath lab or in a critical care unit. But it's an invasive line that goes through the right side of the heart and terminates in that pulmonary artery. Insertion is similar to that of a central line, so use our central line bundle. Now we'll refer you in your book, if you look at the table 25-5, are interventions to prevent infections for central lines, so look at that. With our pulmonary artery catheter, there are multiple ports. So once we connect the hub to the pressure monitoring system, we can continuously monitor pulmonary artery pressures, because remember that tip sits in the pulmonary artery. With the proximal port, it opens into the right atrium. This is the one we can use to give IV medications or fluids. We can actually measure our right atrial pressures, i.e. CVP, with this port. The catheter also has a balloon inflation hub with a valve. A syringe is connected, and we can inflate and deflate the balloon with air. Usually this balloon will hold about 1.5 mLs of air and no more. With the valve, it actually opens and closes the balloon inflation lumen. And that's important that we have a valve so that this balloon is not inadvertently inflated and left there. And we'll talk about that here in a second. We also have a thermistor port, which is the port that measures our core temperatures, and it can also measure our cardiac output. Usually a pulmonary artery catheter is inserted through a large vein, like the subclavian vein. It's inserted through some sort of sheath. So they actually stick the vein, put a sheath in, and then thread the catheter through that sheath. You might even see the brachial vein being used. You might see, which is least desirable, the femoral vein. We don't like to use the femoral vein because of the risk for infection. So here's a picture of what an actual pulmonary artery catheter looks like. So you see at the very end, that red end, that's our cardiac output connection. So that actually connects to the monitor. We have different ports. You'll notice the balloon port that has the syringe attached. The valve is that little white piece with the arrow. You'll also see on the tubing itself different markings, the little black lines. Some are darker, some are lighter, and that measures our distance, so how far that line is inserted. And that's important to note to make sure your pulmonary artery catheter hasn't migrated, because you want it to sit where it was inserted into that pulmonary artery. Also notice on that distal port, so the port furthest away, distal, there's your balloon. With that balloon, when we insert our PA catheters, once we get to a certain point, that balloon's inflated and floated into the pulmonary artery. So it kind of follows blood flow. Once we get into the pulmonary artery, and note that because we see the waveform on our monitors, we're going to deflate that balloon. That's how the catheter will sit. It'll sit in the pulmonary artery with the balloon deflated until we're ready to measure some pressures, and then we can reinflate the balloon. Well, we don't keep that balloon inflated for long periods of time, because if we inflate it, we're actually blocking blood flow to a portion of the lungs. Your lungs could infarct. So just temporarily, we keep it inflated, maybe 10 or 15 seconds, to measure some pressures, and then we ensure that that balloon has been deflated by expelling or sucking all the air out with that syringe, and then closing our valve. So let's watch this video on an explanation of the Swan-Ganz and the details.
I'd like to cover the pulmonary artery catheter here a little bit. Basically, the distal tip of this pulmonary artery catheter is designed to sit in the pulmonary artery, so it can actually measure pulmonary artery pressure. In order to get this into a pulmonary artery, you have to start a central line with a central catheter that has an introducer port, and then you're going to insert the Swan through the introducer port and guide it into the pulmonary artery. So the first question you're probably going to have is how does this actually get into the pulmonary artery, and what prevents this from coiling up like this in someone's atria or ventricle? And the answer is this balloon on the distal tip that I'm going to inflate here. This balloon acts kind of like a sail on a sailboat, because when this balloon is inflated, it follows the direction of the blood flow. And so assuming that this catheter is not coiling up, the blood flow should guide this from the right atrium into the right ventricle and into the pulmonary artery. The second question that you may have is, how are you going to know whether this is truly in the pulmonary artery or whether it's coiled up? In other words, how do you know how far to advance this before stopping? And the answer there is that before starting, you simply just will hook up your Swan-Ganz catheter up here to a transducer tubing, and then you're going to have to watch how the waveform changes as the Swan is guided through the heart. Because the right atrium, the right ventricle, and the pulmonary artery each have a distinct waveform. So if you keep advancing this and all you see is a right ventricular waveform, you're most likely coiled up, and so you're going to need to deflate the balloon and pull back and try again. One thin black line there means 10 centimeters. So there's 10 centimeters, 20, 30, 40, and then a thick black line there means 50 centimeters. And it goes all the way actually up to 100 centimeters. The balloon port is this red port. And so if you want to inflate the balloon, you just connect your syringe to this red port and inflate. The yellow port is always called the PA distal port. And what this means is this lumen here goes all the way to the distal tip of this catheter. The connection to this yellow port is you're going to connect transducer tubing, and the purpose of that is you're going to use that to monitor pulmonary artery pressure and wedge pressure. Now let's go to this blue port here. The lumen to this blue port is much more proximal than the distal lumen, so I can demonstrate this by connecting saline here. And if you follow it all the way over here, you're going to notice that saline comes out of that port right there. We connect transducer tubing to this blue port here, and we use that to monitor central venous pressure. The last port that I want to cover here is this clear port, and sometimes it's a white port. And this lumen is also proximal to the distal tip of the catheter, and it is roughly next to the CVP lumen. The purpose of the clear lumen or the white lumen here is for the connection of all of your cardiac infusion drugs. The last thing that I want to cover on this pulmonary artery catheter is this sterile contamination shield here. And sometimes it's pre-built onto the swan, but sometimes you actually have to put it on yourself. But basically, once the swan is in the right place, you bring this contamination shield all the way down to the hub of the cordis and attach, and that allows the portion of the pulmonary artery catheter that is hanging outside of the patient to remain sterile.
So when we talk about inserting a PA catheter, the nurse's role is to assist the physician in inserting that catheter. It's very similar to a central line insertion. It has to be sterile, but the doctor or healthcare provider will place the catheter into a vein, so like your subclavian, a brachial, IJ, or least desired femoral, and then threads it into the right atrium, where they inflate the balloon, and then the balloon tip floats through that tricuspid valve into the right ventricle, through the pulmonic valve, and into the pulmonary artery, where it sits wedged because that balloon is causing it to wedge into a small pulmonary artery where it can't go any further. Once we determine that that catheter is in the right position in the pulmonary artery, we're going to deflate the balloon, and then that's where that catheter sits. So when when the physician's inserting the PA catheter, we're watching our waveforms. So if you notice, when that catheter is inserted to the right atrium, we have a right atrial pressure tracing, so small in amplitude, kind of like a CVP waveform, which that's what it is. Once we pass through that tricuspid valve into the right ventricle, our waveform becomes larger. Remember, we're in a ventricle, so larger pressure than an atrium. Then it passes through the pulmonic valve into the pulmonary artery. Still see an arterial-like waveform. Then once that balloon wedges, our waveform becomes smaller and you see a wedge waveform. So while we're inserting this line, we're printing these waveforms off for the chart or noting them if it's electronically in the chart. Normal pressures, so right atrial pressure normal is 2 to 6. Right ventricular pressure, we have two measurements, a systolic and diastolic. So normal right ventricular pressure is 20 to 30 over 0 to 8 millimeters of mercury. Pulmonary artery pressure, or PA or PAP pressure, is 20 to 30 over 8 to 15. And then normal wedge pressure, pulmonary capillary wedge pressure or pulmonary occlusive artery pressure, is 8 to 12. So let's watch a video on insertion of a pulmonary artery cath.
For this type of central line, I'm going to float a pulmonary artery catheter. So I'm going to need a type of central catheter that has an introducer port right there and right there. So I've already found the IJ with my finder needle, so I'm just going to go in through that same spot. Hold negative pressure here. Always make sure that you're occluding any kind of catheter directly into the vein so it's not open. So now I hook up my tubing here and I raise it up, and that looks venous to me. If it were arterial, this blood would be coming up. One last thing that you can do to really make sure that this is truly venous is to transduce the waveform, and you need someone that's, you need an assistant to be able to do that. So I'm going to hand that to you. And go ahead and hook it up to our transducer, and we'll look at the pressure. Pressure's good, so this thing is venous. I can now take this off. So I take that off. Go ahead and get rid of that for me. Now that this wire is back in, it's time to float our central catheter. So I'm going to load my cordis here with the dilator. Then when it gets to right here, there's a couple of points that I want to make. Number one, you should never insert this central line in until you've grabbed the wire on the opposite side, okay? Number two is this is going to meet a lot of resistance there at the skin, so you're going to need to make a small nick with the scalpel. Now that line is in, so now I can remove the dilator and the Seldinger wire. All right, once that's in, I'm going to need my assistant to flush this line for me and hook up fluids. So that part's no longer sterile. I can't touch that anymore. Okay, so now that's not sterile anymore, so I'm just going to cover it with this blue drape. Okay, now that that's sewn into place, it's time to float our swan, so I need an assistant here to help me. And man, I'm going to give this to you. That's yours. Now, while he's taking care of that stuff, I'm just going to put this sterile cover over the swan.
All right, so I'm going to hook up this syringe to the balloon port, the red port right here. Now I'm going to hook up this saline to the white port. Now I'm going to hook up my CVP tubing to the blue port. And then I'm going to hook up my PA tubing to this yellow port here.
All right, brother, let's test the balloon. Balloon up. Okay, balloon's good. Deflate the balloon. Okay, go ahead and flush my white port, please. And I can see that it's flushed. Okay, so now that that's flushed, go ahead and hook up my infusions.
My infusion tubing here to the stopcock.
I'll open the stopcock. Okay, now go ahead and flush my CVP, please. Okay, looks good. Go ahead and flush PA. Okay, looks good. We're ready to float this thing. Let's do it. Okay, so just ready to float this now. Why don't you go ahead and inflate the balloon for me?
Balloon is now up.
Okay, so now we're going to look at our pressure waveform to guide where this is as we advance. Okay, so right now you can see him in the right atrium. So I'm just going to advance here slowly. Watch for waveform changes. All right, looks like I'm in right ventricle now, so I'm going to keep advancing. Okay, that looks like PA because my diastolic pressure went up. And it looks like I've wedged right there. I'm going to stop right there. Okay, so once that's floated, I'm going to put that cap on. We're ready to go. I can take this drape off. All right, now I'll take a sterile lap site, please. Just prevent infection. There we go. We're ready to go.
So if you noticed that the healthcare provider was handing the assistant some things and the assistant had blue gloves, which are non-sterile gloves on. So that's our role as nursing, is to help hook up the fluids and pressures, monitor the waveforms, make sure sterile technique has been maintained. Our role after insertion is to make sure we always see a pulmonary artery waveform. That catheter can migrate or slip back into the right ventricle. At that point, you'll see a ventricular waveform. It may be okay to sit there, however, it might not be, and it might cause dysrhythmias. So be on the lookout for that. Also during insertion, when we're inserting the catheter, if it sits in that right ventricle for a long time or the guide wire sits in that right ventricle, it can, what we call, tickle the right ventricle and cause dysrhythmias such as PVCs. If it stays there and irritates it for too long in the right ventricle, you'll see consecutive PVCs or runs of VTAC. So be on the lookout for both of those things. So while that PA catheter is being inserted, we're going to watch those waveforms. So here's a video just kind of explaining where that catheter is in relation to the waveforms. So there's a couple ways we can confirm placement by watching the waveforms. So you might just be watching the monitor as they float that swan or PA catheter in. You may also insert a PA catheter under fluoro, so live x-ray. Either way is fine, so just note that you'll see that.
This is a demonstration of Flip-for-Mac.
So here's our swan inserted into the SVC, into the right atrium. That balloon is inflated. So now we see a right atrial pressure waveform. And that catheter goes through that tricuspid valve into the right ventricle. Notice that waveform gets bigger. We have a systolic and a diastolic now. Now it goes through the pulmonic valve into the pulmonary artery. We start to see a pulmonary artery waveform, so arterial waveform. And then notice that balloon is becoming wedged in one of the smaller pulmonary arteries. So then we see a wedge waveform. At that point, we'll deflate the balloon, and that's where that catheter will sit. You can wedge again just to make sure that you're in the right place. Note the wedge waveform and then deflate your balloon. Remember, we don't want to keep that balloon inflated because it will block blood flow to the pulmonary artery. So just remember, when we do these measurements, we're going to measure at the end of expiration, because when we inhale, we actually change our thoracic pressures and can alter our hemodynamic measurements. We need to use strict sterile technique when we're accessing or changing the dressing on these lines. While we're inserting the catheter, I told you can use fluoroscopy, which is like live x-ray. If you choose not to use live x-ray and we just go by the waveforms, we need to scan and do a chest x-ray immediately afterwards just to ensure we didn't cause a pneumothorax. While we're inserting this line, the client's awake, so you might need to talk to them and relax them. From start to finish, it probably takes about 30 minutes to insert. It is invasive, so before we insert it, we need consent. Explain it to your client. Maybe your client's not able to understand or they're not in a state where they can. So we might need family. During insertion, your patient's going to have to lay flat. And then again, we're going to monitor the waveforms during insertion. Print those or mark them for the electronic chart. Some complications could be pneumothorax, infection, air embolism. Maybe there was air in our pressure line, maybe when we were drawing blood or administering meds. That catheter may slip back into that right ventricle and cause dysrhythmias. If that catheter does slip back into the right ventricle, we have to notify the provider. We can, if they need to, DC the PA catheter. It's just like DCing a central line. However, we cannot, as nurses, it is not in our scope of practice to advance that catheter back into the pulmonary artery. Only a healthcare provider can do that. One thing also to note, that if your patient has a mechanical heart valve, especially a tricuspid or pulmonic, we cannot insert a PA cath. With those mechanical heart valves, they're very rigid. A lot of times they're made from metal and they can clamp on to that catheter, maybe even break a piece off. So one of the measurements that we measure with a pulmonary artery cath is pulmonary artery pressures, or PAP. It's a continuous measure of the blood pressure found in the pulmonary artery. It reflects right and indirectly left-sided heart pressures. Normal's 20 to 30 over 8 to 15. Any condition that increases our pulmonary vascular resistance, so PVR, increases our pulmonary artery pressures. So if we have high pressure in our pulmonary vasculature, that right side of the heart is going to have a hard time pushing against that, thus increasing our pulmonary artery pressures. It indirectly looks at the left side because of the lack of valves between the right side of the heart, the pulmonary vasculature, and the left side. So it kind of indirectly measures it. With the systolic pressure, we're looking at right ventricular ejection pressure. With the diastolic pressure, we're really looking at that pulmonary vascular resistance pressure. Pulmonary artery pressure may be increased with COPD or emphysema, pulmonary edema, PE, left ventricular failure, remember we can look at the left side, pulmonary hypertension, and mitral stenosis. With the mitral stenosis, that valve is really hard and stenotic, so blood flow actually regurges or backs up, thus increasing pressures on the right side. The next measurement that we can measure with only measure with the PA cath is our pulmonary capillary wedge pressure. So our wedge pressure is an indirect measurement of the left atrium and left ventricular and diastolic pressure, just the left side of the heart, but it determines the function of the left side of our heart. Normal is 8 to 12. You can also think of wedge pressure as left ventricular preload. So all that fluid coming back to the left side of the heart, ready to be ejected out. but we will inflate that balloon and wedge off or occlude a branch of that pulmonary capillary bed just beyond that pulmonary artery. And that's what we're measuring. So with wedge pressure, it might be elevated with left ventricular failure, so left-sided heart failure, mitral stenosis, maybe even ARDS. And we'll talk about ARDS in the next unit. So after we obtain a wedge pressure, we need to flush our line, monitor the wedge waveform while inflating the balloon, and deflate within 15 seconds. So you don't want to leave that balloon inflated longer than 15 seconds. We always want to monitor our waveforms, make sure we don't see a wedge waveform with that balloon not inflated, like if that syringe accidentally inflated our balloon, because if it stays inflated, we may infarct a portion of our pulmonary vasculature. So always look at your waveforms, make sure you don't see a wedge waveform. If you walk into your room and note on the monitor that you see a wedge waveform, well, we need to go to the balloon and deflate it immediately. So here's just a picture of what the catheter is doing with that wedge pressure. That balloon's inflated, it's occluding a portion of the pulmonary artery, and it's looking at the left side of the heart. So here's a way or a picture to show you how it looks at that left side of the heart. So remember that catheter is inserted on the right side. It's wedged into the pulmonary artery, all those little arterioles and venules, and then it goes into the left side of the heart. And it can actually see the left side because of the lack of valves between the pulmonary artery and the left atrium. Also with the balloon, when you're inflating it with air, normally we don't use the whole 1.5 mLs of air. You just use enough so that you see a wedge waveform. If you use too much, 1, you may rupture the balloon. 2, you may rupture the pulmonary artery. And 3, you won't get accurate measurements. So just remember, when we're doing any kind of pressure monitoring, we have to use pressurized tubing, which is stiff, non-compliant. Our pressure bag has to have fluids, and it is inflated to at least 300 millimeters of mercury. We can use normal saline or D5W. A lot of times this fluid is heparinized. Also with the pressure tubing, it's important to inflate that bag to 300 millimeters of mercury so that blood flow or blood is not regurged back into our tubing. We're going to zero at least every shift or any time the patient is repositioned. We want to flush our line, our pressure tubing, after we draw blood or measure wedge pressures. Otherwise, while it's continuously measuring those pressures or continuously monitoring, since that tubing is connected to IV fluids and to a pressure bag, it'll actually instill 3 to 5 mLs of fluid every hour. So not enough to really count as intake and output, but just enough to keep that line patent. So with any invasive line, we have specific nursing care. Just remember strict aseptic technique, hand hygiene before and after. If you're going to change the dressing or the caps, you need to be sterile. We usually change the dressing every 7 days. When you're changing your dressing, you have to clean your site, and we usually clean with ChloraPrep. So remember, with ChloraPrep, you got to scrub, scrub, scrub for it to work. We don't apply anything over that insertion site, so no topicals like antibiotic ointment or anything like that. However, you might see a biopatch. Remember, those biopatches are just little round discs that are impregnated with that ChloraPrep. We want to assess the placement, make sure it's in the right place, assess for infection. Change our tubing and solution every 72 to 96 hours. Remember, we can use normal saline or D5W. Level and zero our line with the transducer every shift or any position changes. Monitor our waveforms on the bedside monitor. Make sure we're not in a wedge position where we're not intending to. Make sure it's in a pulmonary artery with that waveform and not slipped back into the right ventricle. And then ensure that our pressure bag is continuously inflated to 300 millimeters of mercury. And like I said, most of them have a little color indicator. So when it's green, you don't have to go up and see that it says 300. If you see the green, you know it's properly inflated. There is another document posted on LMS, and it's the Hemodynamic Invasive Line Care. So with central lines, remember we can measure CVP, but a doctor inserts it using sterile technique. The best side is the subclavian vein. However, the most common side is the internal jugular, so IJ. And then in rare cases, you might see a central line in the femoral vein. We really don't like that because of the risk for infection, but that's the last or only place you can get. Kind of have to go there to obtain access. With central lines, your distal tip is in your superior vena cava. Then after placement, we always need to get a chest x-ray to confirm placement and rule out pneumothorax. So CVPs, remember we're measuring pressure in the right atrium. We can continuously measure it with a central line. The complications of a central line could be infection, thrombosis, or air embolism. So usually if it's a small, teeny tiny air bubble, we're not worried, but if it's greater than 10 to 20, so a full syringe full of air, you may see signs of air embolism. Patient may complain of confusion, lightheadedness, anxiety. They may even become unresponsive. If this happens, what we need to do is place our client in Trendelenburg on their left side and give O2. Make sure your line hasn't been displaced. Secure all your connections so it's not getting air through. Maybe our tubing is not connected all the way to our line. Maybe it fell off, came disconnected. Always use a 10 ml syringe. If you're going to administer anything, use that SASH technique. So saline, flush your line, give your medication, flush it again. And if that line isn't going to have IV fluids continuously, go ahead and heparinize it if your patient's platelets are within normal range. Arterial lines, remember there are invasive line to measure blood pressure. The most common arteries are radial or femoral. Do your Allen's test. Sterile technique for insertion and changing the dressing. Make sure whatever extremity that A-line is put in, that it's visible at all times and not under the covers. I told you another good way is to put the pulse ox on that extremity. If you notice your pulse ox waveform not so good, then perfusion has been compromised and your A-line might be the culprit. We're going to monitor their blood pressure. We'll use this blood pressure to titrate our vasoactive medications. We can also draw labs and ABGs, but remember we don't infuse medications through an A-line. Remember your waveform, we're looking for that dicrotic notch, which signifies the closure of that aortic valve. Assess your extremity for color, blanching, make sure your pulse is still good in whichever artery it's in. If we're going to DC our A-line, we want to hold pressure for 5 to 10 minutes. Make sure we still have a good pulse and color and temperature of that extremity, but don't peak while you're holding pressure. With our pulmonary artery cath, just remember we need to watch our waveforms. Make sure we're not in the wedge waveform. Remember our sterile dressing, we usually change it every 7 days if it has a biopatch. If it doesn't have a biopatch, then possibly every 72 hours. But we can also change it as needed. So if your patient's platelets are low and they're bleeding around the site, we can change it even if it's been a couple hours. We just have to maintain sterile technique. Label all your tubings. Label if it's an IV line, what the medication, if they have a drip going through it. Measure or label your lines as to what line it is, distal, proximal. A lot of times our lines are already labeled for us, but if they're not, you can move your patient that has a pulmonary artery catheter, so don't be afraid to turn them. They can get out of the bed. Just remember you'll have to zero your transducer every time they move. We're going to monitor our waveforms, look at our ECG, monitor for dysrhythmias. And then of course we're going to monitor our values for response to treatments. So maybe their CVP is high. We gave them some furosemide. Now an hour later, let's look at their urine output. Has it increased? Has their CVP decreased? Monitor for air embolisms. Okay, so be sure, guys, to look at this content in chapter 25 of your MedSurg book and look at that extra Word document for the hemodynamic monitoring nursing care.